The moderators for this oral abstract session are Dr. Sarah Mansfield, who's Assistant Professor of Pediatric Surgery at Nationwide Children's in The Ohio State University, and Dr. Roshni Dasgupta, who is Professor of Surgery at Cincinnati Children's, University of Cincinnati. So.
Okay, yeah. I'd ask everybody to come and take their seats. We have our second oral abstract session. The break is over. Please sit down. Okay. We are going to start today with assessing the diagnostic accuracy of TIRADS in pediatric thyroid nodules, a multi-institutional review. Going to be presented again by Dr. Sachi Srivastava from Nationwide Children's Hospital.
So again, my name is Sachi Srivastava, and I'm the current Surgical Oncology Research Fellow at Nationwide Children's. Thank you again for the opportunity to present today. We have no relevant disclosures. So in conducting this research, our primary goal was to assess the efficacy of the Thyroid Imaging Reporting and Data System, or TIRADS, in predicting malignancy in pediatric thyroid nodules. The significance of our findings lies in the demonstration that application of both the adult and pediatric TIRADS scoring system can significantly enhance the accuracy of malignancy prediction in pediatric thyroid nodules and can effectively reduce the number of unnecessary biopsies while minimizing the risk of missed malignancies. Thyroid nodules in children and adolescents, though uncommon, carry an increased risk of malignancy at smaller sizes. Currently, the approach to ultrasound-based risk assessment for pediatric thyroid nodules largely mirrors that of adult nodules, following similar guidelines set forth by the American Thyroid Association. However, given the unique consideration of pediatric patients, there's a growing need to evaluate and refine these assessment methods to ensure optimal management and outcomes. The ATA guidelines for children with thyroid nodules emphasizes the importance of considering ultrasound characteristics and clinical context when predicting malignancy in pediatric patients. Originally validated in adults, TIRADS utilizes ultrasound characteristics to predict malignant potential and guide recommendations for fine needle aspiration biopsy. The validated adult TIRADS scoring system takes into account 5 ultrasound characteristics for nodule classification: composition, echogenicity, shape, margins, and echogenic foci. TIRADS 1 and 2 encompasses benign nodules. TIRADS 3 and above demonstrate increasing concern for malignancy, and the addition of size criteria is used to recommend the need for biopsy. Because thyroid nodules in children can be malignant at smaller sizes than in adults, we developed a novel pediatric TIRADS scoring system. The pediatric scoring system takes into account smaller size cutoffs for recommending biopsies at the TR3, 4, and 5 levels when compared with the adult criteria. Our objective was to assess how well TIRADS performs in children and adolescents with thyroid nodules. We hypothesized that the application of TIRADS criteria into our assessment, we could improve our ability to predict malignancy and thereby reduce the number of unnecessary biopsies recommended for pediatric thyroid nodules. Building upon a previous single-institution study conducted at Nationwide Children's, we conducted a multi-institutional retrospective analysis spanning from 2015 to 2020, including patients under the age of 21 with thyroid nodules. Both pediatric and adult TIRADS scores were assigned by pediatric radiologists retrospectively. We compared their performance to the ATA guideline-based biopsy recommendations. Our study encompassed a cohort of 260 unique patients with a total of 291 thyroid nodules. Among these patients, 78.8% were female, with a median age of 14.9 years. Here is the distribution of nodules that underwent fine needle aspiration biopsy as classified by the Bethesda criteria system within our cohort. The majority of nodules fell into the Bethesda 2 category. We evaluated the biopsy recommendations produced by each of the criteria for all nodules included. Our findings revealed that while ATA guidelines recommended biopsy for 76.6% of nodules, application of the adult TIRADS criteria reduced this to 35.1%, whereas the pediatric TIRADS criteria reduced this to 49.5%. When assessing the ability to identify malignant or suspicious cytopathology, ATA guidelines recommended biopsy for 82.2% of nodules. It would have missed one malignancy and had a sensitivity of 97.3%. Adult TI-RADS criteria resulted in biopsy recommendation for 38.6% of nodules, would have missed two malignancies, and resulted in a sensitivity of 94.6%. The novel pediatric TI-RADS criteria resulted in biopsy recommendations for 53.4% of nodules, would have missed no malignancies, and resulted in a sensitivity of 100%. The accuracy of the novel pediatric TI-RADS criteria of 62.3% was almost double the accuracy of the ATA criteria at 32.6%. We additionally evaluated the ability of the criteria to identify malignancy for those confirmed on surgical pathology. ATA guidelines recommended biopsy for 97% of nodules, would have missed one malignancy, and resulted in a sensitivity of 97.8%. Adult TI-RADS criteria recommended biopsy for 71.7% of nodules, would have missed three malignancies, and resulted in a sensitivity of 98.3%. Utilizing the novel pediatric TI-RADS criteria, biopsy was recommended for 79.8% of nodules, would have missed no malignancies, and again resulted in a sensitivity of 100%. Both the adult and pediatric TI-RADS criteria had accuracies greater than that of the ATA criteria. In conclusion, our study findings demonstrate that the application of both adult and pediatric TI-RADS scoring to thyroid nodules in pediatric patients significantly enhances the accuracy of malignancy prediction compared to relying solely on the current ATA size criteria. Additionally, the utilization of the pediatric TI-RADS scoring has proven particularly impactful, as it effectively eliminated unnecessary biopsies in many children without missing a single case of thyroid malignancy within our cohort. Looking ahead, we are excited to announce our plans for a larger multi-institutional study through the Pediatric Surgical Oncology Research Collaborative. This study aims to validate our current findings and establish the routine use of TI-RADS scoring for pediatric thyroid nodules. I just wanted to quickly thank everyone, all of the institutions that were a part of this study, as well as my mentors who are mentoring me throughout my 2 research years, Dr. Aldrink, Dr. Mansfield, and Dr. Schwartz. So thank you.
All right, nice job, Sashi. This is Angela, one of the surgical fellow at Pittsburgh. Now that you have the luxury of institutional data, have you examined the variability of location where the ultrasound was obtained? For example, were most ultrasounds completed at the main children's hospital, or some of these obtained at non-specialized facilities that maybe primarily do adult ultrasounds?
So that's actually one of the limitations of the study with ultrasound characteristics. It's very dependent on the operator. So we did not specifically look at where these children were getting ultrasounds within this study, but I think it's really interesting to look at and something that we should include in future studies. However, I do want to say that this is a screening tool. So the hope is that no matter where you're getting your ultrasound done, that this criteria would hopefully be better than the current ATA criteria.
I have a quick question for you. Given that we see a lot of ultrasounds done in non-children's hospitals, do you feel like there would be any difficulties in incorporating a pediatric TI-RADS classification among adult radiologists?
So that's definitely something to consider. I do think that there would be some difficulty, but I think that the promise of this is that this has already been validated in adults, and so they are used to using the TI-RADS criteria, and really the biggest difference is the size criteria. And so I think that that's easily integrated into the present practice.
Okay, thank you.
Thank you.
All right, our next speaker is going to be presenting to us on an assessment of narrative operative reports for Wilms tumor resection using consensus component criteria. This is Dr. Zach Morrison from St. Jude.
Good afternoon. My name is Zach Morrison. I am a pediatric surgical oncology fellow at St. Jude. And this afternoon, I'd like to tell you about the work we've been doing examining the content of our narrative operative reports for Wilms tumor patients at our institution. We have no disclosures. This research was performed to assess gaps in pediatric surgical oncology documentation. We're presenting it today to share our findings and suggest a means of improvement, the synoptic operative report. Clarity and precision are essential in medical documentation, particularly in surgical oncology field. Narrative operative reports provide the author with a general template for surgical documentation, allow a large degree of flexibility with data inclusion, and are easy to customize. Synoptic operative reports take advantage of electronic medical records to give the user a detailed template with pre-designated fields. They provide the opportunity for semantic clarity between authors and institutions, and they are easy for data mining. Synoptic operative reports have been shown to include more essential information, be more complete, and contain more quality of care metrics when compared to narrative operative reports. Synoptic operative reports have been well studied in several subspecialties of adult surgical oncology, but they are less studied and reported in pediatric surgical oncology. A multinational group of authors has developed and published a standardized operative template for use in pediatric surgical oncology. This template is broad enough to be used for the resection of any type of tumor. It was developed through an iterative Delphi process with specific focus on utility in low-resource settings. The template and full paper are available by following the QR code at the top of this slide. In the present study, we conducted a single-center retrospective review of narrative operative reports at our large tertiary pediatric oncology referral center. Patients were included who had undergone resection, unilateral or bilateral resection of Wilms tumor between January 2022 and July 2023. We recorded the presence or absence of 11 key documentation components of the published standardized pediatric oncology operative report shown on the previous slide. These 11 components were chosen for their oncologic significance, their surgical importance, or their significance for multidisciplinary patient care. Inclusion rates for each key documentation component were calculated as simple percentages. We found 39 operations for Wilms tumor. 4 operations were excluded, leaving 35 operations for analysis. 22 of the reports documented unilateral procedures, and 13 of the reports documented bilateral procedures. Templated headings in our EMR included the indication for surgery, specimen naming, intraoperative complications, and estimated blood loss. When considering unilateral and bilateral operations together, the most consistently documented operative report components were estimated blood loss, indication for surgery, intraoperative complications, and specimen naming, all of which had 100% documentation rates. The least consistently documented components were intraoperative tumor spillage, the completeness of resection, the presence or absence of metastatic disease, and surgeon assessment of vascular involvement, all of which had 40% or less documentation inclusion rates. I want to emphasize that the percentages listed in this table are documentation inclusion rates. They are not rates of intraoperative occurrence. For example, looking at the lower portion of the table, we can see that intraoperative tumor spillage or absence of spillage was documented in 40% of the operative notes examined. It is not the case that tumor spillage occurred in 40% of the operations examined in this study. In comparing unilateral and bilateral operations, we found no statistically significant differences in the inclusion rates of any of the 11 key documentation components. Documentation of the surgeon's assessment of vascular involvement was somewhat more common in unilateral than bilateral operations. However, this was not statistically significant. 3 of the 35 narrative operative reports contained all 11 key documentation components. 2 of the 35 reports contained only 5 of the 11 key documentation components. In conclusion, we found inconsistent inclusion of the 11 key documentation components in narrative operative reports for pediatric Wilms tumor resection at our institution. Synoptic operative reports offer a way to streamline surgical documentation, enhance communication between multidisciplinary care teams, and ultimately contribute to improved patient outcomes. Importantly, the present study used as its gold standard an operative report template designed to be particularly useful in low-resource settings, where regular communication between multidisciplinary care team members may be difficult. In those settings, operative reports may need to contain information not only about the operation, but also about key elements of the patient's disease. Modification of standardized templates to local environments is therefore essential. Thank you for your attention. I'd be happy to take any questions at this time.
Zach, that was a great talk. I was curious about your inclusion of metastatic disease in the OPNO. Is that just because this is for other resource settings? Is that why you included it?
Yeah, I think it is particularly helpful in lower resource settings. It can also be useful, of course, in more higher resource settings, such as our own institution. For example, many of our patients come from other facilities and get their primary oncology care at other centers. And the operative note may be one of the things one of the documentation components that accompanies them back to their home institution. And so that it would be important for those treating physicians to know that as well.
Did you look at performances between your 5 surgeons at St. Jude with whether there were any correlations as to who was maybe a better actor, or if there was a way to do some feedback on accomplishing the...
Can I ask a follow-up question?
I was going to say, I see Dr. Talbot laughing. We did not. So 34 of the 35 operative notes were actually written by surgical fellows. We also did not look at which fellows performed the best. Yeah, I think as an institution, it leaves room for change. And I think one of the things that we're working towards is developing synoptic reports that may be specific for each type of tumor, and that would kind of eliminate the inter-user variability.
Ken?
And Gal Stony Brook, as you may know, there's already work ongoing now to try to figure this out from a national standpoint. Can you give some advice to us after your work on how to make this work well across the entire COG? Thanks.
Yeah. So at our institution, we've started to adopt synoptic reports since about October of this past year. I think one of the things is that it needs to be easy. It can't include, a whole lot of extra steps outside of what we're normally used to as surgeons. So it should be something that's well integrated into the electronic medical record or into the kind of reporting system following your operation. And ultimately it should be a form that is, click-proof and drop-down menus and that kind of thing, and doesn't require a whole lot of extra work on the part of the surgeon. Thank you.
All right, our next speaker will be Christine Corkum from Colorado, presenting performance of a novel pediatric extracranial solid tumor fertility loss risk assessment tool on identifying patients at high risk for treatment-related fertility loss.
Great. Thank you for the opportunity to present our work. I have no disclosures. So why did we do this research? Kind of going back to Dr. Weldon's talk from earlier, that the majority of our patients that are diagnosed with cancer will survive their disease. So it's really important to look for the future and how to improve their quality of life. From previous studies, we know that for survivors of childhood cancer, future fertility potential is a significant quality of life factor. Many patients and their families attribute fertility preservation consultations and procedures as giving them hope for the future. At our institution, over 2/3 of patients who receive a fertility preservation consultation for high risk of treatment-related fertility loss go on to pursue a procedure. But despite this all being very important to our survivors of childhood cancer, there's currently no tool for treatment-related infertility risk assessment for this patient population. Why am I presenting it today and why is it important? I'd like to share with you our novel pediatric oncofertility risk tool that we've developed to make steps towards standardization of pediatric oncofertility risk assessment. Some additional background. We know that treatment for pediatric extracranial solid tumors is typically multimodal and can be highly gonatotoxic. Gonatotoxic therapies, including alkylating agents, heavy metals, need for stem cell transplant, and radiation exposure to the gonads can put patients at high risk for treatment-related fertility loss, and it is these patients that are candidates for fertility preservation. Just to review, for our prepubertal patients, testicular tissue and ovarian tissue cryopreservation are options for future preservation of their fertility. For postpubertal patients, we have a few more options given their sexual maturity, which include testicular sperm extraction, sperm banking, oocyte, and embryo cryopreservation. I can tell you the current process for risk identification is quite cumbersome, and let's just walk through that. So a pediatric patient comes in as diagnosed with an extracranial solid tumor. They either get treated according to or enrolled on a COG treatment plan. It takes a provider to understand that this patient may be at risk for future treatment-related fertility loss. Then manual summation of those alkylating and heavy metal chemotherapies according to the treatment roadmaps, applying these to a CED or cyclophosphamide equivalent dose calculator, and then using those cumulative doses to cross-reference against published risk tables. The other option is that this patient does not get identified as someone at risk, and no fertility loss risk assessment occurs. In our group, we label this as a missed opportunity. And as I mentioned at the beginning of this talk, there's currently no standardized tool for treatment-related infertility risk assessment for our pediatric extracranial solid tumor patients. So our group sought to try to streamline this process and make steps towards standardizing by developing a pediatric oncofertility risk calculator. And we did this by creating an algorithm to assign treatment-related infertility risk using these 5 variables: solid tumor diagnosis, the COG study and enrollment arm for the patient, patient's sex, their pubertal status, and whether or not they have received any radiation exposure. The algorithm would run and pump out a risk identification category, including high level of increased risk, significantly increased risk, and minimally increased risk. And these are all based on published risk stratification tables through the Oncofertility Consortium. For the purposes of this study, I'd like to focus on those that are highest level of increased risk. To test the performance of our algorithm and our tool, we utilized a retrospective cohort of pediatric extracranial solid tumors that were treated at our institution from 2017 to 2022. We assigned infertility risk at 2 different time points: the time of diagnosis, which we labeled as the expected risk, and then after completion of therapy, which we labeled as the observed risk. We were able to use the tool and apply it to 240 pediatric extracranial solid tumor diagnoses over that time period. And when we looked at that cohort, nearly 40% at diagnosis and 50% at completion of therapy were deemed high level of increased risk. When we looked at our tool's performance, for those the expected risk or at the time of diagnosis, it had a high sensitivity and specificity for accurately risk identifying these patients. But when we looked at those patients for observed risk or at the completion of their therapy, we saw reduced performance. So we delve into this a little bit further. We found that patients who had metastatic disease at diagnosis had a reduced performance of the tool, specifically when you looked at specificity, positive and negative predictive value. In addition, patients who experienced relapse of their disease during the study period also had a reduced performance of the risk assessment tool, or those who experienced a protocol change during their treatment. So in conclusion, pediatric extracranial solid tumor fertility loss risk tool correctly stratifies patients at the time of diagnosis, but does have reduced performance in accurately assessing the risk at completion of therapy, specifically for those subgroups of metastatic disease at diagnosis, relapse of disease, or those who experience a protocol change. Therefore, re-engagement of the tool may be necessary to re-examine risk when treatment plans change. We do recognize that there are limitations. Patients are enrolled on new COG protocols, so this will require tool updates to remain accurate in terms of risk assessment. And also, some of our patients are diagnosed with rare tumors that may not be captured in this tool, and these patients will require consultation to perform an accurate and up-to-date risk assessment for future treatment-related fertility loss. Our next steps are currently prospectively validating this tool at Children's Hospital Colorado, and we're hoping to expand this tool to include all oncology diagnoses, with the ultimate goal of doing a multi-center implementation study to look at improved rates of fertility preservation consultation. Thank you, and I'm happy to take any questions.
Christine, this is fantastic. I mean, this really is what we need to take this to the next level, right? Because right now, as you allude to, this is a very manual process. And I think the places that do it successfully do it because they have people whose whole job is dedicated to navigating this complex labyrinth. And this has the potential to make this accessible to the masses. But how do you really get it to people? I mean, have you thought about what the next steps would be to make it a tool that everybody can use, whether it's reaching out to Todd to talk about getting it on Stay Current or something like that, where it can not only be available, but to your point, be constantly updated so it's actually accurate?
So the way we're doing it right now is to just do this retrospective and prospective validation to make sure our tool accurately assesses these patients. With the thoughts of developing a web-based or app platform, or even better, integrating it into EMR systems. So it's part of the normal workflow at a new diagnosis, or when there's treatment changes like I alluded to. But I think it's really important to recognize that it's not a one-off risk assessment, and that these treatment plans change, especially for our solid tumor patients, and that's something that we should consistently think about.
I was going to say the other aspect would be to try to implement it within Beacon, which is the chemotherapy kind of pathway system in Epic, where then if there was a change in roadmap on Beacon, it could prompt sort of a reassessment of the fertility risk. So great work.
Thank you.
Another question for you. What is the utility of doing one of these fertility assessments at the end of therapy when you've already been exposed to your cyclophosphamide dose and your fertility is pretty much gone?
Right, so I think we don't know that for sure for all of the patients. There are risk thresholds like you saw on that table I presented, but some patients may not have gotten risk assessed up front, and understanding their level of risk may help provide a prompt interventions like doing egg harvest before their AMH levels and their FSH and LH levels drop, and just giving patients information. The other thing is just to look at how well we are predicting what their actual treatment regimen will be. And we know for some disease processes up front, they are high risk regardless of what they're enrolled on. But there are those patients, with other diagnoses that as more information comes in, their risk status actually escalates. And so it's kind of nice to know along the process where they fall in terms of risk assessment. But there are patients that can still have fertility preservation even if they've gone beyond this threshold, but it's recognizing that they may need to intervention early.
Thank you.
Thank you.
So my co-moderator will now present enhanced recovery after surgery for pediatric abdominal tumor resections.
Thank you. It's an honor to present for all of our study authors who have nothing to disclose. Enhanced recovery after surgery, or ERAS, is an evidence-based standardized approach to improve recovery perioperatively. It has become standard of care in several adult operations where it has been demonstrated to decrease complications, shorten length of stay, decrease opioids, and improve nutrition and patient satisfaction. It is increasingly used in pediatric patients, but has not been rigorously studied in pediatric oncology patients. It's particularly important in these patients as they often require intensive multimodal therapies, and due to these therapies or the tumor itself, patients often experience nutrition alterations, deconditioning, significant opioid exposures. Exacerbating any of these perioperatively can lead to delays in adjuvant cancer-directed therapies. This was a multi-center prospective study with propensity-matched historical controls, with the goal of decreasing 90-day complication rates. We included all patients older than 1 month of age undergoing resection of an abdominal tumor between 2020 and 22. Our matching variables are listed, as well as our statistical approaches. A protocol was developed utilizing accepted ERAS principles with modifications from the study team. The protocol outlines 20 process measures with specific definitions. A few of the highlights include counseling to set expectations and a clear carbohydrate load the morning of surgery. Regional analgesia was tailored to the case and encouraged to be on during the operation. Euvolemia, normothermia, and opioid reduction goals were explicitly stated. MIS approaches were encouraged when oncologically feasible. NG tubes were avoided, and feeding was advanced at a minimum of clears on day 0 and regular on day 1. Multimodal pain regimens were ordered from the operating room, and opioid goals were explicitly stated. Implementation was tailored at each site and included key stakeholders. During dissemination, it was emphasized that the process measures were goals and should not override clinical judgment. It was unlikely that patients would achieve 100% of the targets, but that did not disqualify them from the study. We enrolled a total of 95 patients into our prospective ERAS cohort. These were compared to 95 historic controls that were well matched for all of our variables with age, gender, weight, race, prior therapies, and diagnosis shown here. This was our scorecard with historical percentages included for reference. We reviewed similar scorecards during our regular audits. Again, some things to point out. The carb load the morning of surgery was achieved in 77% of patients. During early audits, we appreciated how poorly we were achieving normothermia. Therefore, sites made targeted interventions and were able to increase this throughout the course of the study. Regional analgesia rates were actually high in both cohorts, but despite that being similar, the opioid reduction goals were actually more likely to be met in the prospective cohort. The MIS approach was driven by the oncologic feasibility and performed at similar rates to historic patients. Twice as many patients left the OR without an NG tube, and post-op opioid goals were achieved in 74% of our patients. When we look at how the protocol impacted specific data points, the median operating room time was not different between the two groups with similar regional analgesia rates. Intraoperative crystalloid volume decreased from 14 cc's per kg per hour to 5 in the prospective cohort. Patients received their clear liquid and regular diets 2 days earlier in the ERAS cohort. Patients were liberated from their IV fluids and got out of bed 2 days sooner. Opioid consumption dramatically decreased from 0.23 to 0.08 in the setting of higher adjunctive pain med utilization. Despite decreased opioid consumption in the prospective cohort, pain scores were not negatively impacted, but were actually better in ERAS patients on days 2 and 3. There was a trend towards shorter length of stay and shorter time to clearance for chemotherapy, and no difference in ED visits or readmissions. For our main outcome, there was a significant reduction in number of complications as they were reduced in half. This improvement in complications was seen across grade 1, 2, and 3. Importantly, there was no difference in the need for nasogastric tube reinsertion postoperatively, even though we advanced diet sooner. In conclusion, in pediatric surgical oncology patients, ERAS is feasible, decreases complications, decreases opioid consumption without worsening pain scores, promotes earlier mobilization, and proves diets may be advanced sooner without negative effects. There are limitations in utilizing a historical control for comparison, and it should be noted that ERAS had already permeated many of our centers prior to the start of the study. Moving forward, we have several deeper analyses planned, including differences in compliance, evaluating our patient surveys, and a deeper look at our adjunctive pain meds. Additionally, operations are heterogeneous, and fine-tuning this protocol to organ-specific procedures may further improve outcomes. We'd like to thank all the people involved at each of the centers. It took a village to do this project. There's too many to list here, and I'd be happy to take any questions.
Chris?
Roland from Boston. You have a lot of very specific measures that are easy to document. Opioid quantities, fluid quantities, regional anesthesia is kind of a throwaway term. It could be epidurals, right? It could be paravertebral catheters, it could be tap blocks, it could be pain pumps. Is that really a measurable variable for you, or did it have to be more specific, and would that have changed your outcome?
So we did have some leeway in what providers could choose. For example, if you were doing a laparoscopic surgery, you may not want to do an epidural, you would do a local wound block or a tap, or a wound catheter for smaller incision. We did capture the specific type of regional and the amount that was used and which medications were used in that. So we have all that data as well for the main manuscript.
But did you have an a priori or would there be a role for an a priori discussion to say to the anesthesiologist, just like, don't use so much opioid, can you use pathway X or pathway Y? And then
yes, absolutely. At St. Jude, we had good collaboration with our anesthesiologist, and specifically requested non-opioid analgesic when we could in their epidurals. We used a lot of clonidine as an adjunct of pain medicine.
Kibby Williams, DC. That was pretty much my question, but did you have a sense of whether the majority were epidurals or?
Oh, yeah, the overwhelming majority were, yes.
Okay. Thank you.
great job. Obviously, I'm biased that this is useful. I would say most everybody in this room knows what ERAS is, right, at this point. So what to do with this? I mean, do you think people are not using it because they don't know about it, or they're just not using it because they don't want to use it? And can that be changed? Because I think the evidence to support it is pretty overwhelming.
Yeah, I think that, the different generations are more comfortable with ERAS. I only know ERAS, so I've advanced diets my whole training more quickly. It took some convincing for that to happen with others, and I think data like these will help support that. There's also some fear of using Toradol in oncology patients, which we have that data as well. We have kidney function that we're going to analyze. So there's a lot of things that we hope to alleviate some fears with the study.
So I have a question for you. Obviously, getting out of bed early and feeding early and all those things, implicitly you'd think they'd be able to go home earlier, right? So why, and I think one of the things in terms of acceptance of ERAS is proving that you're actually going to have a little shorter length of stay. Yeah. So one, why do you think that you didn't have a shorter length of stay that was significant? And two, was there any subsets that might have had a shorter length of stay?
Yeah, we do plan to analyze specific tumor types separately. We did actually have a significant length of stay, except for one patient got kicked out of the study, and so that significance went away, so it was very close. We specifically did not pick length of stay as a surrogate because it is so multifactorial. There are social reasons, there are consulting services reasons. So the complications we felt would be a better surrogate to say these patients, are in a better shape heading into their adjuvant therapies. But that's the reason we didn't pick it as our primary outcome, although we subjectively felt like they were leaving earlier.
Erica?
Hey, Sarah, this is great work. Thank you for presenting this. I have more of an operational question. So to pull something off like this, undoubtedly, surgeons, we're all in, but this takes anesthesiologists, the nurses, the PACU, the floor. How do you operationalize something like this?
You got to find someone passionate in each of those areas and hold on to them. So we were lucky to find an anesthesiologist at each of the centers that felt as passionately as we did, and they were able to get their colleagues on board. And if they weren't on board, they were usually okay with shuttling these patients to specific providers who liked the protocol and did our cases frequently. But you're right, it was there were way too many people to put on that slide. This took a village to pull off. All right, our next presenter is John Lundstedt, postoperative fever in pediatric oncology patients undergoing solid tumor resections.
Thank you for that introduction. Again, my name is John Lundstedt. I recently finished up my undergraduate degree at The Ohio State University, and I'm going to be talking about postoperative fever in pediatric oncology patients undergoing a solid tumor resection. There are no disclosures. Postoperative fever is a common occurrence in patients undergoing surgery, and especially in those who have surgery for cancer. These patients commonly undergo an extensive and costly fever workup. However, there is scarce literature examining postoperative fever in pediatric surgical oncology patients. The purpose of this study was to determine incidence and risk factors for postoperative fever in patients undergoing surgery for cancer and to determine the utility and yield of the tests ordered for this population. This was a single institution retrospective chart review from June 2018 to June 2023. Patients with a fever defined as a temperature greater than or equal to 38.0 degrees Celsius within the first 3 postoperative days were identified and included. A generalized linear mixed model was used to evaluate statistical predictors of fever. The variables identified included the administration of perioperative antibiotics, preoperative chemotherapy, presence of central lines, operation type, bowel resection, the length of surgery, wound class, hypothermia, blood transfusion, hyperglycemia, and neutropenia. The diagnostic tests included in our workups for fever included urinalysis, urine cultures, blood cultures, and chest x-rays. 222 patients met the inclusion criteria for this study. There were 95 males and 127 females, with ages ranging from 3.65 days to 40.35 years. 48 or 22% of the patients had neuroblastoma. 47 or 21% of the patients had a liver tumor. 28 or 13% of the patients had a Wilms tumor, and 99 or 45% of the patients had some other type of tumor morphology. 154 patients, or 69% of the population, had a laparotomy as their primary tumor type, or primary surgery type. 35 or 16% of the patients had a laparoscopy. 17 or 8% of the patients had a thoracotomy, and 16 or 7% of the patients had thoracoscopy. 94 or 42% of the patients developed a fever within 72 hours following surgery. 31 or 33% of these febrile patients were placed on empiric antibiotics. 69 or 73.4% of the febrile patients underwent a workup for their fever, where the average cost of a workup was $455. Only 3 or 1.35% of the patients had positive findings from their fever workup, where one of the patients had a positive culture coming from their left nephrostomy tube, which was considered contaminated, while the other two positive cultures came from blood cultures, where both patients also demonstrated hemodynamic instability. The factors that were statistically significant for predicting the early postoperative fever included male sex, intraoperative transfusion, postoperative transfusion, Foley catheter, neutropenia, and sarcoma histology. The limitations for the study included the small number of infections, which limited our ability to determine predictors of infections. And the fever workup practices in our institution may not be generalizable, where the utilization of cultures and radiographs likely represented our own institutional practices and may not accurately reflect trends in other institutions. In conclusion, postoperative fever is common in pediatric cancer patients undergoing surgery. However, infectious etiology is rare and workup is costly. In this study alone, $31,395 in costs to the hospital could have been saved from unnecessary fever workups. These patients are also treated empirically with antibiotics, where we are exposing patients to antibiotics when not necessary, which is detrimental in the era of needed antibiotic stewardship. Therefore, fever alone should not warrant a workup within 72 hours following solid tumor resection. And testing for febrile postoperative oncology patients within 72 hours of operation should be reserved for patients with significant symptomatology or other risk factors. Thank you. I'm happy to take questions.
So, nice work.
Thank you.
I have a couple questions. So, are those patients on the surgery service when they're spiking the fevers? Or are they on the oncology service?
Surgery. No? Oh, I'm sorry. Then I do not know that question.
So, the oncology service. So, they have like a knee-jerk response to fevers and starting antibiotics and do a workup because they're used to neutropenic patients. So, have you provided them this information and have you been able to impact their behavior?
I would say that this is a work in progress and we're still working on that manuscript.
Thank you so much for doing this, because same thing happens in my institution. Fevers, the night of post-op, and next thing you know, the patient has all of this stuff going on, including x-rays and antibiotics. My question, so great work. Question, the neutropenia, was that post-op neutropenia, or were you able to see if there was a difference between neutropenia pre-op? And if so, how neutropenic?
I'm not sure, but I can get back to you with that. We didn't differentiate between neutropenia pre or post-op.
Great work. Was it during COVID? And how many of these patients got a COVID test and a nasal swab for viral infections as well, which would add to your costs, right? So I'm pretty sure Cincinnati does that as well as everybody else. So did you calculate that?
No, we did not calculate COVID tests.
Okay, thank you. Yeah.
Hi, Ken Gauss, Stony Brook. When I was at Seattle, we had a protocol where patients post-operatively were managed on a similar protocol you're talking about. They were all on the surgery service. So my comment is we found pretty much exactly the same findings. I would hope that you publish this so that this gets put out into the community so that people don't overreact and spend too much money. So great work.
Thank you.
Tim?
This is a really important topic, and I think It depends, at our institution at least, on literally what floor you're on. If you're on the surgical floor, it doesn't matter what service you're on. If you're on the surgical floor, you're fine. If you're on the oncology floor, where the nurses have been ingrained that a fever means cultures, that's a barrier that you have to break.
Yeah, this work really stemmed out of frustration with oncology and intensivists, automatically starting things on our patients, and John did a fabulous job, so thank you.
All right, thank you.
All right, we will continue with the evaluation of image-defined risk factors, assessment in patients with intermediate risk neuroblastoma. This is a report from the Children's Oncology Group study, ANBL 0531, presented by Dr. Erin Brown.
Good afternoon. Thank you very much for the opportunity to present this work on behalf of the Neuroblastoma Committee. These are our disclosures. We conducted this research because neuroblastoma is a common pediatric tumor with heterogeneous clinical phenotypes. The treatment plan and the overall outcomes are largely dependent on risk group, and in 2005, the International Neuroblastoma Risk Group Collaborative developed pre-treatment risk stratification guidelines that included the assessment of image-defined risk factors, or IDRFs, at the time of diagnosis in order to preoperatively identify tumors that may be challenging to resect. The goal of this study was to assess the IDRF determination at the local institutional level and compare that to a central review committee. This study is important because accurate and reliable staging of children with neuroblastoma is an essential component of their care, and accurate and reliable IDRF assessment is a critical part of the staging effort. A tumor is defined as having an IDRF when there is radiographic evidence of vascular encasement or invasion or compression of critical structures. Each body compartment has its own specific criteria, which are listed in this table here. IDRFs are meant to serve as a surrogate to identify tumors that may be challenging to resect. We also suspect that there's a role with aggressive tumor biology with tumors that have IDRFs. I'd like to point out that in 2011, the guidelines for IDRFs involving the renal pedicle changed, and the encasement of the renal vessels was no longer required, and any contact with the renal vessels was to be considered an IDRF. This change in classification was available for the central reviewers, but was not available for the local review during the study. ANBL 0531 was a therapeutic clinical trial for children with intermediate risk neuroblastoma who enrolled between 2009 and 2011. A secondary aim of this study was to assess local versus central review IDRF assessment. Of the 404 patients enrolled in the study, 211 went local IDRF assessment at their institution. 3 of these patients were excluded due to poor image quality, leaving 208 patients who underwent central IDRF assessment by central review committee that consisted of two pairs, including 1 surgeon and 1 radiologist in each pair. First, looking at concordance between the local and the central sites, this was assessed in 3 different statistical analyses. First, if either of the central reviewer pair deemed that an IDRF was present, then an IDRF was considered present per central review. When comparing local and central sites, they agreed 52% of the time. In the next analysis, cases in which the initial central reviewers disagreed were excluded, and this improved concordance between the local and the central sites to about 57%. In the third analysis, when there was agreement at either the first or the second central review, these cases were included, and again, we saw about 57% agreement between the local and the central sites. However, you can see that in all 3 analyses, the kappa coefficient corresponded with poor concordance between the local and the central sites. Focusing next on concordance among the central reviewers, the central reviewers agreed about 82% of the time. This meant that they also disagreed about 18% of the time, which corresponded to moderate agreement. In 31 out of the 38 cases in which there was disagreement, the radiologist identified an IDRF as present while the surgeon did not. Those 38 cases in which consensus was not reached went on to a second blinded review by the second central reviewer pair. If 3 of the reviewers agreed, then a consensus was reached, and this occurred in 25 out of the 38 cases. This meant that 13 cases went on to an unblinded adjudication with all 4 of the central reviewers. They were able to reach consensus in 12 out of the 13 of these cases. Just to dive a little bit deeper on these 13 adjudicated cases, the specific IDRFs in question are listed here. The surgeons changed their determination to match that of the radiologist in 8 out of 13 of these cases. To focus in on those involving the renal pedicle, all 5 of these tumors were abutting the renal vessels but not encasing them. And in all 5 of these cases, both radiologists deemed an IDRF as present, while the surgeon said that one was not. I think this highlights an interesting aspect that surgeons likely take surgical risk into consideration when they're interpreting IDRFs. There are several important limitations to this study. First and foremost, this study was performed when IDRFs were still a relatively new concept. It is certainly possible that a more contemporaneous study of this would show better results. Number 2, the change in the renal hilum IDRF definition likely impacted the results between the local and the central review. And then finally, the local IDRF assessment was not standardized to a specific person, and so that may have impacted the quality of the results at the institutional level. However, this is still the first study to compare concordance from local and central sites for IDRF assessment in a national clinical trial. And what we saw was that concordance between local and central review was poor. Concordance amongst experienced central reviewers was moderate, but disagreement still existed in up to 1/5 of the cases. This suggests that greater standardization in education is needed to ensure accurate IDRF assessment. And I think an important point is that the differences between IDRF interpretation from the surgeons and the radiologists suggest that not all IDRF are created equal in terms of predicting surgical risk. This is an area of interest for the COG committee and hopefully a future study. I'd like to thank the 0531 study committee and the surgeons on the neuroblastoma committee for their mentorship in this opportunity, and I'd be happy to take any questions.
Aaron, that was a great study. Did you have enough patients? So 0531 is pretty old now. Did you have enough patients over time to see if there was an improvement? Because I know it's going to be a long time before you can get the next trial data.
We don't have that for this study. The central review was performed after enrollment, so I think that's a little bit of a difference too. It is something that's going to be assessed in 1531, so we'll have to wait for that data.
Thank you, Aaron. I think this study is very interesting. Again, my question is, we know the concordance between the local and the central, but who's accurate? Do we have the data on that? Because I think eventually you want to know is actually who make the right call, right? It's not just who agreed with who, but who makes the right call. So I think that's probably a question that I would like to know. Any data on that?
It's a great question. I think if I'm being brutally honest, my trust in the quality of the data from the central view is much more robust than the data from the institutional level. Not because the institutions are doing a bad job at IDRF assessment, but we did not mandate who is going to fill out that information. A lot of the answers were unknown at the local site, and these were included in the analysis, and I'm not sure that that was necessarily a fair comparison. It may just be that the person filling out that CRF doesn't know what an IDRF is or how to find out that information.
Weldon from Boston. So how many surgeons actually did your local IDRFs?
I'm sorry.
How many surgeons actually determined the local IDRFs?
I don't have that data. My suspicion is that very few.
So in AHEP 0731, it was 0. And the post-text in AHEP 0731, the surgeons filling it out, was 0. And what we found when we did that, and there would be a paper forthcoming comparing the exact same issue on 500 cases, is we as surgeons, and there are 5 of us versus the 3 radiologists, saw things very differently. Because one saw it as not necessarily a 2D view, but they saw it as a non-functional view. Did it cross into Couinard segment 6 or 7 or not? Whereas a surgeon would take it and say, how do I take that piece of data and then turn it into a functional outcome? And so for about 60 hours of meetings going through this with everybody, it became apparent that though the question is A or B, what you do with the information is never one answer. And so the discordance between never having the surgeons at the local level at any point is problematic, because when you go to a central review, the surgeons are involved. And then ultimately what you do with that information, and I don't know about everybody else's tumor boards, but that's one of the most hotly, dissected areas, because I don't think there is a clear thing. And then the other thing that we found is the utility of the studies at diagnosis all over the board. And what you can get over the course of 5 years as the techniques get better and better will then help your RDRs become more and more apparent, because then you can truly say is it 180 degrees, is it 270 degrees, and things like that. But that was a remarkable study. Thanks.
Thank you very much.
More question for you. As you know, there are different IDRFs, right? Did you look at specific types of IDRFs that might have had more concordance, or did you even be able to break that down?
Yes, so we did look at IDRF assessment, radiologist compared to surgeon in the different body compartments. The only one where there was a statistically significant difference was cervical IDRFs, but there was a trend towards significance for abdominal and thoracoabdominal as well. All right.
Thank you.
Thank you.
Our next presenter is David Rodeberg, presenting outcome and risk factors for patients with perineal and perianal rhabdomyosarcoma, a report from the COG Soft Tissue Sarcoma Committee.
Good afternoon. I'd like to thank IPSO and APSA for the opportunity to present our work from the COG, in addition to be the probably only abstract presenter requiring readers. Everybody else is young enough not to. All right. So I'm going to be talking today about perineal and perianal rhabdomyosarcoma. So I have no disclosures to make, financially no conflicts, other than that the primary author is within arm's reach of me. So the research was performed is because we haven't looked at this site at the COG for quite some period of time, and the CWS as well as the IPSO, our European colleagues, had looked at this, and we wanted to compare our own data to them, but in addition to see if we had made any progress over time. This work will go on to help us identify kind of some risk factors and things that we could potentially do to improve the outcome for these patients, but also it's going to provide the information that is necessary for the CWS, IPSO, and COG to sit down and come up with a common pathway for local control for rhabdo at this site. So this is a really uncommon site for rhabdo, and it's approximately 2% of all rhabdo cases. And the outcome is bad. I mean, it is, depending on the study, somewhere between 20 to 50%. And that's because it has a number of bad things associated with it. It's bad tumor biology. It's a terrible place to try to excise the tumor and to get local control. And in addition, it usually presents with advanced disease. So what we did is we pulled the data from 4 different clinical trials from COG. This gave us a whopping total of 51 patients. And then we pulled them together, and our follow-up was approximately 6.5 years. So 51 patients were eligible. 38 of those had perineal disease, and 13 had perianal disease. About half of them were females. a lot of them, 65%, were over 10 years of age, and 76% had alveolar histology. Given the long period of time, we don't have fusion status on all these patients, so I can't give you that information. Again, 3/4 of them were greater than 5 centimeters, a half were metastatic at presentation, 84% were invasive into surrounding structures, and 65% had regional nodes that were positive. So what were some of the differences between those patients that presented with kind of local regional disease versus those that presented with metastatic disease? Well, as you can imagine, the patients that were metastatic presented with older age. The tumors were more likely to be invasive. They were going to be larger in size, greater than 5 centimeters, and they were going to have clinical nodes that were positive. Now, again, histology didn't enter into this, right? Normally, histology has a bad prognosis if it's alveolar or fusion positive. But here, because so many of the patients were alveolar positive, there was no way to tease out whether or not that was an independent prognostic factor. Now, the metastatic disease was present in bone marrow and bone in about 64% of patients, distal nodes in half, and lung in about 1/3. So almost none of these patients had a complete resection with normal margins up front, right? So only about 15%, 16% had group 2 disease, meaning that microscopic disease was left behind, or that they had the positive nodes that were sampled, or a third of them were group 3 patients. The remainder only had biopsy. And then a delayed resection after induction chemotherapy was performed in about 25% of patients. Almost all of them, 88%, received adjuvant radiotherapy. And here are the outcomes for the patients overall. Event-free survival was 38% at 5 years. And then you'll notice that overall survival really isn't any better. It's at 42%. And this is why. 55% of patients relapsed. 6 were local, 22 were metastatic. All relapses recurred within 2 years. And metastatic relapse was more common in patients that were older than 10. Again, that's kind of what you would expect to find. But the 5-year overall survival after relapse was 0 for local relapse and 10% for metastatic relapse. So once they relapse, you don't salvage these patients at all. So on the other hand, if they don't relapse, that half of patients that don't relapse, their overall survival at 5 years was 90%. So it would seem like one of the things that we would want to do as practitioners is try to get optimal local control up front to prevent relapse. So in univariate analysis, the event-free survival was significantly dependent upon age greater than 10 years, overall survival, age greater than 10 years, but then also group. But honestly, that comes down to metastatic disease. It's not whether you're a group 2 or group 3. It really is kind of just group 4. But then when you kind of put it all together, none of them really came out for event-free survival. And overall survival, it was only patients over 10 years of age that was a significant prognostic factor. So, in conclusion, patients with perineal and perianal rhabdomyosarcoma, they have many known poor prognostic factors. Age greater than 10, alveolar histology, I would assume FOXO fusion status, but I can't prove that. Metastatic disease at presentation, large tumors, invasive disease, and regional nodes that are already positive. Now, these results, honestly, they're no different than they were 30 years ago. It's the same results. We have not improved the outcome for these patients at all. In addition, when you compare it to CWS and EPSSG, our European colleagues aren't doing any better. So the salvage of the relapsed patients remains horrible, and only age over 10 appears to really have a significant impact on overall survival. And that's it. I'd be happy to take any questions.
Hi,
sir.
David. I think I know the answer, but was there any case that was known to get preoperative radiotherapy? No.
No, that is not part of our...
Because it's a difficult area to operate, and that may be something that you could add.
Yeah, that's not usually part of our paradigm here for our local control, and so none of these patients had neoadjuvant radiotherapy.
David, thank you for your paper. Were you able to interrogate the patient history or in terms of hospital visits or family practitioner? One of the big problems is that these patients can present with perianal disease, subacute perianal disease, constipation that's been refractory, and they're being passed from pillar to post before it's too little and too late. And that's something I think is incredibly important, or condylometer or things like that. And, how do you develop an early warning tool? Because that's where we need to go, isn't it, really?
Yeah. No, you're absolutely right. Our data does not collect that information, so I have absolutely no idea kind of how long they were floating around the system getting misdiagnosed. But the literature is replete with case reports and information showing that patients with disease in the site get mistaken for, perianal abscesses and things like that. It just gets delayed. Nick?
Great work. I mean, though if the message is going to be that we need to be more aggressive with local control, I think it gets to the point you made, which is what is involved in terms of chemotherapy, surgery, and radiation, because if you're going to wait to radiate them in this location, it's going to require an exit and an APR where they're going to have a big defect that you're going to have to flap gracilis up into and then radiate that. I mean, it seems like it would require a paradigm shift in terms of how we sequence those three things. But with that kind of outcome, I think we have to do something different.
Yeah, I think that when we sit down and try to come up with a group consensus for the instruct, so for both our European colleagues and ourselves, I think that's something that is going to be part of the conversation. Is we can't keep doing the same thing over and over and expecting a different result, but it's also then going to require buy-in from our oncology colleagues that they get nervous when we get aggressive, right? So we're going to have to come up with a paradigm where we can make it seem like it's a reasonable alternative, and to show them these data to say we need to do something different. But it will be a combination of radiation therapy and surgical therapy.
Because, what's another primary site that's this bad? Right?
Yeah.
In Rhabdo, there's not.
Not many at all, no.
Yeah. Great work.
John, thank you.
Very nice, sir. Thank you for that. Just a question. You told that in patients who did not relapse, 90% survived. So what has happened to 10%?
I'm sorry?
So what happened to 10%? They died of toxicity or?
Boy, I don't know. I'm sorry, I don't have that information.
So maybe this factor of relapse was calculated within a certain time frame.
Yeah.
Because the reason for that in this 10% should also be a relapse.
I would think that they still did. Yeah.
Thank you.
Yeah.
Hey, Dave, thanks. Great presentation. I think about this a lot with the local control issues in difficult sites like this. What do you think the openness of the soft tissue sarcoma field would be to early adjuvant immunotherapy in, like, for example, CAR T-cell therapy or BiTEs or other antigen-directed therapy when the immune environment is very propitious right after surgery? Is that something you think the field is ready to consider, or not yet?
I don't know. Does that therapy work? Just kidding. So as we had talked a little bit earlier today about like neuroblastoma and trying to get down to an earlier intervention surgically and then to kind of come in and get a minimal residual disease so that you can do some targeted therapies, I think that certainly is amenable and would be a good approach to take. And I'm going to stop because Jenny's looking at me. Thank you.
All right, we're going to go to our next presentation. Ms. Thee. It's the impact of surgical margins in wide local excision of pediatric melanoma, an argument for a more conservative approach. This is going to be presented by Anthony Basta.
Thank you for the opportunity to present our project. We have no disclosures relevant to this study. Melanomas in adults have widely been studied in various multi-center clinical trials. The rarity of pediatric melanoma makes it challenging to study, and the literature is limited. Care and treatment for pediatric melanoma have largely been extrapolated from adult guidelines, including guidelines for margins for wide local excision. Little evidence supports wide margins in children, which can impact postoperative outcomes, including healing and cosmetic outcomes. Pediatric melanoma, although rare, is the most common skin cancer in children. It accounts for 8% of cancers in adolescents and up to 60% of diagnoses not meeting traditional criteria. Modified A, B, C, D criteria include amelanotic, bleeding, bump, color uniformity, de novo, any diameter. Since 1907, many surgeons considered wide margins greater than 5 centimeters and aggressive surgical approaches appropriate. However, it was found in the 1960s and 70s that vertical growth was a better prognostic factor than lesion diameter. The current National Comprehensive Cancer Network guidelines recommend wide local excision with 1 centimeter margins for melanomas 1 millimeter or less in depth, 1 to 2 centimeter margins for melanomas 1 to 2 millimeters in depth, and 2 centimeter margins for melanomas greater than 2 millimeters deep. These guidelines are based on multiple randomized trials that found that 1 to 2 centimeter margins could treat intermediate thickness melanomas between 1 to 4 millimeters deep. In comparison, 1 centimeter margins were associated with higher recurrence for melanomas than 3 centimeter margins for melanomas thicker than 2 millimeters. All studies have been conducted in adults. Achieving surgical margins recommended by the NCCN is often challenging, especially in small children and body regions with difficult closure. We hypothesize conservative surgical margins and wide local excision in pediatric melanoma will not alter postoperative clinical outcomes. We included all patients ages 2 to 21 treated for cutaneous melanoma between 2007 and 2023. Exclusion criteria included patients with incomplete data or melanomas arising from congenital nevi and/or from neuroectodermal neurocutaneous origins. Patients were categorized in groups of surgical margins less than 2 centimeters narrow versus greater than or equal to 2 centimeters wide. Margin group size was based on the maximum cutoff recommended by the NCCN guidelines. We collected data across demographics, primary tumor characteristics, primary resection type, complications, treatment, and recovery. Additional treatment was reported as receiving adjuvant chemotherapy, immunotherapy, targeted therapy, and/or radiation. We analyzed categorical and continuous variables between groups. Multivariate logistic regression was applied to determine the association between covariates and binary outcomes. Covariates included age, tumor location, and Breslow thickness. Binary outcomes included surgical margin group, meeting NCCN guidelines for margin size, complications, and required intervention. Required intervention was based on all patients requiring non-pharmacological treatment for complication-related management. Of the 96 patients undergoing wide local excision at our institution, 59 met the inclusion criteria. 37 patients were excluded. 31 patients had missing data, including missing surgical margin, and 6 patients had melanoma from congenital nevi and/or neuroectodermal neurocutaneous origins. 61% of patients had narrow margins, while 39% had wide margins. When comparing patient demographics, the proportion of patients in each group was relatively consistent across age, sex, and race. Those in the wide margin group were more likely to have nodular or unclassified type of melanoma, thicker lesions, and stage 3 disease. Tumor characteristics otherwise were comparable between the two groups. Most patients underwent wide local excision with sentinel lymph node biopsy as a primary procedure. Rates were comparable between the two groups. 17% of patients experienced complications, and complication rates were not significantly different between the two groups. 25% of patients underwent complete lymph node dissection as a secondary procedure. Of these patients, 53% experienced complications. 41% of patients received additional treatment, and there was no difference between groups. All patients who underwent adjuvant treatment received immunotherapy, except for one patient who received targeted therapy. Of the patients receiving immunotherapy, 1 also received chemotherapy, and 2 also received radiation therapy. There was only 1 death due to metastatic disease, and no patients experienced local recurrence. In our multivariate analysis, head and neck melanomas were less likely to have wider margins and margins that met the NCCN guidelines than compared to trunk and extremity melanomas. Patients greater than 10 years of age were less likely to have wider margins. There was no significant difference in the rate or type of postoperative complications and the need for intervention for patients between both groups. We acknowledge the limitations of our study, which include small sample size, potential selection bias, missing data, and patients lost to follow-up. We determined that head and neck melanomas were less likely to have larger margins and meet NCCN guidelines. Narrow margins resulted in similar complication rates and median follow-up to a wider margin in children and adolescents with cutaneous melanoma. No patients experienced local recurrence. These findings support the viability of a narrow wide local excision margin. Considering the limited research regarding excision margins of pediatric melanomas, this study highlights the importance of including pediatric patients in future clinical trials that evaluate surgical margins in melanoma excision. I'd like to thank my mentor and thank you for the opportunity. Thank you.
Thanks for presenting. Great job. So I would argue that 2 centimeters is wide, even though you called it. So a couple of questions. Why did anyone have greater than 2 centimeter margins in your study? Because that's not called for with NCCN. What were the complications in those? I'm assuming they were all wound or graft related complications. And then, I think your study perfectly highlights, as we're all awaiting the Melmart study, which is comparing 1 centimeter to 2 centimeters in adults. And hopefully that will be able to be applied to children as well. So nice job.
So if I recall the question, to answer the first question regarding surgical margins they're greater than or equal to 2 centimeters, I actually don't know. I recorded from the op note, and so I didn't look into those patients, but I'll get back to you and look into it. What was the other question? Oh, complications. Can I get back to you on that? So, sorry about that.
So thank you for your beautiful presentation. I have just a question. Do you know who performed the surgery in your group? I mean, the melanoma is a disease that can be excised by dermatologists, by pediatric surgeon, by plastic surgeon. So do you have any data about this? And do you think that different surgeon can influence the outcome?
Yes, that's a very good question. I just collected data across all the surgeries, so all the surgeons at our center, and that's actually a very good point because as you notice, we have a pretty wide exclusion criteria. A lot of patients were excluded, and part of this was we didn't have. We now have a synoptic op note, so you can actually put in the surgical margins. So since this study goes back a long period of time, I know we also switched at our institution. We switched EMRs. And so it's pretty difficult to go back in time and find a specific surgical margins.
Thank you.
Andrea Haystix in Washington, D.C. I now officially feel old. Then I have to say, I'm going to refrain from saying I rise to remind the group. I was part of the UT group at MD Anderson when we talked about doing this study, so I congratulate the group on getting it done. And as far as the answer to the previous question, it was pretty much myself and Dr. Mary Austin doing most of those cases from 2007, with a couple of them sprinkled in by the other surgeons at MD Anderson. But importantly, at the time that we wrote the largest paper on pediatric melanoma because of the large population we had there, we identified that there were the patients that were less than 10 years of age had a higher incidence of sentinel lymph node positive disease, but a lower incidence of death, which prompted the question about the margins that you're answering today. So we made an observation. I remember having a short talk with Dr. Austin about, why are we doing all these margins that Dr. Austin brought up? You've got this little tiny face and you're trying to get these margins in, and that the outcome of this child, prepubertal child, is going to be good no matter what, and you really don't want to impact the cosmesis. So I just wanted to emphasize how important it is to go from a simple observation of, is this really critical to the oncologic outcome of this patient to make the cosmetic aspect of this child's face worse, or is it not? And to encourage young people like yourself to keep asking those clinical questions to get those answers.
Thank you.
Our last presentation for this session is Racial and Ethnic Survival Disparities in Pediatric Oncology Over Time, an analysis of the SEER registry, presented by Nicole Coos.
Thank you for the opportunity to present to you today. We have the following to disclose.
So prior studies have demonstrated existing racial and ethnic disparities in multiple aspects of oncologic pediatric care. For this reason, we sought to investigate how have racial and ethnic disparities in mortality among pediatric oncology changed over time using the SEER registry. Although pediatric cancer is rare, it remains one of the most common causes of death in this population. Advances in pediatric cancer treatment have been a major success story in modern medicine, with mortality rates decreasing by over 50% in the last 50 years. The benefits of these advances have not been shared amongst all groups, as demographic and socioeconomic disparities have prevented this from happening. Unfortunately, this is not new. Racial and ethnic disparities have been well documented across a wide variety of pediatric cancers. Given these known disparities and the increasing focus on improving equity and outcomes from healthcare, we designed the study to examine the temporal trends in outcome disparities over the last 50 years. We specifically focused on all-cause mortality, hypothesizing that disparities in pediatric cancer mortality would improve over time for Black and Latino patients compared to non-Latino white patients. De-identified data was used from the SEER registry. We included patients less than 20 years of age. Anyone who lacked data on race, ethnicity, cancer type, or survival were excluded. Patients were divided by race and ethnicity into the 4 groups as you can see on the screen. We sought to evaluate the trends in disparity by studying the interaction between race, ethnicity, and decade. A multivariable Cox proportional hazard model controlling for age, sex, and cancer diagnosis was used to evaluate these associations. About 50,000 patients were included in the study. Non-Latino white patients represent the majority, with Black and Latino patients representing 11 and 11.7% respectively. Age and gender were relatively similar between the groups. However, we noted an overrepresentation of older patients in the white population. Rudimentary staging was similar between white and Black patients, but we did note that more patients had distant disease in the Latino and other race ethnicity groups. As expected, over sequential decades, more patients of Black, Latino, or other groups were included in the study. We did not control for stage, as we believe that this can possibly help identify some disparities, regardless of the cause. All race and ethnicity groups had improved survival over time. Kaplan-Meier curves were created for each of the 4 racial groups. As you can see on the left of the slide, white non-Latinos had improved survival from 62 to 87% from the 1970s to 2010s. On the right of the slide, Black patients also demonstrated improved survival from 59% to 80%. Latino patients on the left of the slide had an improved survival from 63 to 83%, and this was also similarly seen on the right of the slide with other patients. After controlling for cancer type, age, and sex, the hazard ratio for mortality decreased significantly each decade. However, all groups continued to have significantly higher mortality than non-Latino white patients. When using linear contrast to normalize hazard ratio for all race and ethnicity groups to 1 in the 1970s, an increasing disparity is demonstrated in each successive decade. While the hazard ratio for mortality in non-Latino white patients improved by 76% over the last 5 decades, Black and Latino patients only improved by 64 and 62% respectively. This indicates that contrary to our hypothesis, disparities between Black and Latino patients and their non-Latino white counterparts have not been improving since the 1970s. They've been getting worse. This worsening trend was also found to exist in our exploratory subgroup analysis. Using the interaction between race, ethnicity, and decade, hazard ratios greater than 1 indicate worsening disparities between Black and non-Latino white patients over time. Broad groups of tumors, as demonstrated here, showed consistent and significant increase in the disparity. More specific tumor types, such as CNS tumor, Hodgkin, non-Hodgkin lymphoma, neuroblastoma, and rare tumors, all showed a consistent trend toward worsening disparities over time, but the 95% confidence intervals often crossed 1. Of note, Wilms tumor did demonstrate decreasing disparity over time in Black compared to white patients. In Latino patients, the overall trends were similar, although some of the individual tumor types were different. In this population, Wilms tumor and hepatic tumors actually showed no change in disparities over time. Other types, such as bone tumors and soft tissue sarcomas, demonstrate at least a trend towards increasing disparities in the Latino population. Our results demonstrate that over the last 5 decades, Advances in diagnosis and treatment of pediatric cancers have led to an improvement in overall survival among all groups. However, contrary to our hypothesis, we found that disparities in cancer survival between white children and children in other race and ethnicity groups have actually increased. As these results were generally consistent amongst all tumor types examined, it is challenging to provide insight as to what the aspect of care was the problem: the diagnosis, surgery, long-term therapy, or follow-up. I do want to note that this study does have several limitations. First, we use the SEER database, which is known to be primarily used to study adult cancers. We did not decide to control for higher stages, as I'd mentioned previously. Outcomes other than mortality were not often available, and lead time bias was not accounted for. In conclusion, the novel aspect of the study is the temporal trends that we examined, which show that cancer survival disparities between white children and their Black and Latino peers have been increasing over time. This finding suggests that despite the widespread focus on ameliorating health disparities and aspiring to equity and outcome, current efforts are losing ground. We call for renewed efforts to understand and address the worsening disparities faced by children, including access to care and health insurance, implicit and explicit biases in care, barriers to appropriate communication, and trust within the healthcare system. Thank you to all of our collaborators on this project, and I'd be happy to take any questions.
Thank you. Erica Newman from Mott, Michigan. So depressing way to end the day. But I have a question, actually. And I hope my question will give us some hope and inspiration. So race, I think, is just one component of the picture. Were you able to see, and so there is some data that it actually is more related to social deprivation and poverty. And I know that racial minorities have higher incidence of social deprivation and poverty, so it's confusing. But I'm just wondering if your data set, and I don't know this about SEER, but if there was information about household or neighborhood poverty and or social deprivation that might give us just a little bit more insight into why the disparities are worsening.
That is an excellent point. It is not something that we looked into in this study. We just wanted to see how disparities, the trend changed over time. But I think that that is one of the many possible reasons why the disparities have been worsening, aside from mistrust in the healthcare system possibilities, lack of some cultural barriers. I think there's a lot that needs to be investigated as to what we can do to help prevent better this.
So SEER is not a great database to look at children. That being said, there's been a few papers that might help strengthen when you try to go on to help your strength behind your conclusions here. And one is there was a paper that took SEER data and then looked at the institutions they were treated at and how many of them were treated at POG, CCG, and now COG. And that, when they did a multivariate analysis, that was the factor above race that did it. One of the things that you should strengthen yourself when you write this or if you get feedback is Dr. Lavorne recently published using the COG data, Wilms tumor, and looking at race, which has a fairly robust thing, and it was very similar to your results. So that is encouraging about the validity, but I would hope you would do that because that'll provide more strength and get people to do it, because SEER is not great for children's because it just doesn't collect things in the way, and there's been papers that have come out that just don't reflect reality.
Yeah, absolutely agreed, and we recognize that, except that SEER does have the most robust information on cancers, but I know there's the National Childhood Cancer Registry, which is also coming to try to be able to fill that gap, but unfortunately the data doesn't date back to the 1970s.
Thank you.